Good afternoon, everyone. Okay, good to go. Today it's my pleasure to introduce Dr. Kati Pasanen, who will present today on lower extremity injuries in youth team sports. Can they be predicted? Can they be prevented? Dr. Pasanen started her career in physical education and coaching at Varela Sport Institute in 1993, where she focused on periodization in ice hockey. And you might have figured this out already. If you want to tick off a Canadian, refer to it as ice hockey instead of just hockey alone. And after that, she did her undergraduate in physiotherapy in 1996 at Karolia University, where she looked at musculoskeletal disorders in factory workers. Next, she did her master's degree at the University of Jyväskylä, graduated in 2005, where she did epidemiology of injuries in floorball. So I had to look this up before I did this introduction. I was going to say a thing or two about it, but I noticed that Kati has a few videos of floorball in her presentation, so you can wait for later on to find out what that is, if you don't already know. And then later she did her PhD at the University of Tampere, which she graduated in 2009, and she looked at injury prevention by using neuromuscular training, which you might hear a bit about today. And this is one of her most proudest accomplishments because it actually changed some of the clinical practice and sport training in Finland as a result of her PhD. And that's always nice to hear when sometimes you finish your PhD and it just sits in the library somewhere collecting dust. So it's good to see this being used. And after her academic training, or during her academic training, Kati also was a coach for a number of different sports and physiotherapist, including floorball, ice hockey, and rink ball, which is another sport that I was unaware of. And before starting at Calgary, she was a research and development manager for 5 years. When asked about her future plans, Kati said she plans to continue to develop novel methods for sport injury prevention, and more importantly, she wants to visit Hawaii, which hopefully will be a lot easier from Calgary than from Finland. One interesting fact is that after coming to Canada, Kati was able to pick up hockey once again, or ice hockey, I suppose. And she actually plays in the Monday staff hockey that kinesiology hosts. And I was surprised that everyone was on board with letting her play and did not have any leftover bitterness when Canada lost to Finland in the World Junior Championships. So with that being said, I'll pass it over to Dr. Pasanen, and we'll hear a bit about her research.
Thank you very much, Michael. Thank you for having me here. I'm going to talk about lower extremity injuries and their prevention today. And I'm very happy to see some familiar faces here. So some of you have seen these videos several times, what I'm going to present here. But I like to use videos because by watching, for example, real-life injury situations, we can learn something. We can learn something for injury prevention by that way. For those who don't know where Finland is, it's what did I do? It's up here, up north, and actually Finland is very similar compared to Alberta here. So we have big cities, we have winter. We have funny sports. We don't play rodeo, but we have our own funny sports like reindeer racing. And of course, we play hockey. And I played hockey for 10 years, and then I was a coach in female hockey teams. But somehow I ended up in floorball. I don't actually know how this happened, but since 1998, I was a coach in many different floorball teams, mainly in men's teams. And I was also a coach for our women's national team for 4 years. So that's been a big part of my research as well. And for this reason, quite many of my projects have focused on injuries and risk factors of injuries and prevention of injuries in floorball. And by the way, you play floorball here in Canada as well. So I found this, and actually I have seen Team Canada playing in World Championships. They are not so good as we are, but maybe someday, yeah. This is probably the only thing you remember from this lecture, so yeah, check this out, Floorball Canada. This is the UKK Institute where I worked for a long time. I started there at 2003 as a master student, and I worked there until I moved here, until 2017. And the UKK Institute is a leading research institute for health promotion research in our country. And most of our studies focus on physical activity and health, but we also have studies in injury prevention. And I was responsible for sport injury prevention studies and also responsible for knowledge translation. So I have worked in close collaboration in Finland with our Coaches Association, Physio Association, Sports Physio Associations, and Olympic Committee, and we have done excessive implementation work in the field of sports injury prevention, and that's been fantastic. So today we can see, for example, neuromuscular training used quite widely in different sports. However, injury rates are still very high, so the problem is not solved. And I'm here now. I have worked here for a year and a half, but I still have 4 ongoing studies in Finland, which I am leading. And today I am going to talk about this profits risk factor study and soccer study. I'm building my own research program here at the University of Calgary, but so far I don't have anything about those plans to present, so I will focus on these projects I have in Finland. And I also have 5 PhD students there working in my studies, and also 2 master students, so those guys keep me quite busy. Time difference between Calgary and Finland is 9 hours, so it's a little bit tricky to meet them every week, but nowadays it's possible because you can use Skype and face calls and so on. My research has focused on neuromuscular training as an injury prevention method, and my special interest has always been lower limb injury, and also especially knee and ankle strains in team sports. And I have also done studies investigating risk factors for these injuries in youth team sports. And before I move forward, I would like to show you the video about floorball, because this describes quite nicely what kind of sport it is. So it resembles floor hockey, I guess. Was it floor hockey? Yeah. It's very fast game. Repeated direction changes. Body contacts are not allowed, but in adult games they are very common. And injury rates are alarming. Ankle sprains, knee ligament injuries, concussions are very common in floorball players. And there are 5 field players on the court at the same time from one team, and a goalie. This was a concussion here. And some of those guys, especially in men's floorball, are professional players, so that's what they do for their living. Okay, that's enough. Yeah, not a big surprise that injury risk is high. And this data is from adult studies, but the injury risk is high also in youth floorball, and knee and ankle are the most common types of injuries. Knee ligament injuries, ankle ligament injuries, and severe knee injuries is a big problem. ACL injury rates are really, really high. And as my research as a PhD student, I focused on neuromuscular training in floorball and prevention of those common injuries by neuromuscular training. And this study was conducted in early 2003. We started the pilot study, and then we did epidemiology collection during the first year, and the next year was the randomized control trial. And primary outcome was non-contact lower extremity injuries. And we used a very basic neuromuscular training program. And actually, this program and these exercises were exercises that I had used in ice hockey when I was a coach in ice hockey. So in Finland, before ice hockey practices, we usually do dryland warm-up and that kind of stuff. I guess it's same here in Canada, but not in our shinny. But so same exercises as I used in ice hockey, but that was not a research setting. I used here in floorball, and these results were very promising. So we were able to reduce injury risk by 66% in intervention group compared to control group. So that was huge. And these teams intervention teams were asked to do this warm-up at least once a week, but we recommended to use it 1 to 3 times per week. And it took about 20 to 30 minutes to do. And they performed this warm-up during 1 season. And the control group was asked to continue their usual warm-up strategies. I will come back to the neuromuscular training in the end of this lecture. I will now move on to our risk factor study, which is a collaboration study with the Norwegian research group. And this study was designed right after the first World Congress in Sport Injury Prevention that was held in Oslo in Norway in 2005. So this was designed a long, long time ago. And at that time, there was only one prospective study that had investigated association between knee valgus, dynamic knee valgus movement, and ACL injury risk. And that was our main objective here, to investigate whether the knee valgus is associated with ACL injury risk. And Norwegians, they collected only ACL injuries during their 8-year prospective follow-up. We collected information about all time-loss injuries in our cohort. So in Oslo, they focused on female sport in handball and in soccer, which are also high-risk sport, and knee injury rates are high. And we focused on floorball and basketball in Finland in top-level junior league. So they were younger players than in Oslo, in Norway. And second video describes typical ACL injury situations in different sports. So interestingly, most of ACL injuries occur in non-contact circumstances. So they are not a result of direct hit to the knee or lower limb. And this is same in both males and females. Yeah, this number 11 here. Ouch. And this is floorball. This girl is wearing a knee brace, so she probably have had some sort of knee problems before this injury. But again, typical valgus movement, dynamic valgus movement. This is from London Olympics. And of course, there are some external factors as well. So Snow conditions, playing surface may play a crucial role as well, but the mechanism of these injuries is somewhat similar in different sports. So perhaps we could avoid the valgus movement by improving strength, coordination, knee control. Oh no, not, we don't watch it again. So biomechanical studies have estimated that ACL injury takes place within 30 to 40 milliseconds after initial foot contact. So that's really fast. An injury mechanism includes knee valgus, internal or external tibial rotation with small knee flexion angle. So these are the typical components of injury mechanism in different sports. So in our risk factor study, our overall aim was to investigate anatomical, biomechanical, genetic, and demographic risk factors for all lower extremity injuries, including ACL injuries. And our plan was also to do pooled analysis later with the Norwegian data. So we collected the information of injuries using similar methods in 2 countries. And altogether we invited 27 teams, 22 of them agreed to participate, and our main cohort contains basketball and floorball youth players, 403 youth players. And these players were invited to participate in baseline testing every May 2011, 2012, 2013. And after these tests, we collected information of injuries and exposure. Exposure means training hours and game hours. And also after the last follow-up year, when we collected information of injuries and exposure on a weekly basis, then we continued this study for a year and a half, and we contacted these players twice, and we asked if they had sustained any ACL injuries. But during these 3 years, we collected information of all time-loss injuries. And we were interested in knee valgus, but we had many other tests here too. So this was our test battery, similar test battery that our Norwegian friends used as well. And it took about 6 hours for one player to complete these tests. But we bought lunch and snacks and funny little things for them. So they were really happy, actually, I think. I think we gave them a T-shirt as well. So, yeah. And so it was a long day for players. And there were 3-dimensional motion analysis of vertical drop jump. And then we also investigated more sport-specific movements. And then we had strength tests, a ligament laxity test, flexibility test, balance tests, and anthropometrics, so a bunch of different tests. And during this day, they also completed baseline forms, and and we took a blood sample. And then during the following year, we collected information about their sport participation and time-loss injuries. And this is a video about some of those tests we use. So here we measure ACL laxity, and then hip abduction strength, isometric strength, and hamstring flexibility. And again, I would like to remind you that the study was designed in 2005. So if we would start the study again, we would probably use some different tests here, but that was then. Ligament laxity. And then we had 4 different balance tests. Also on platform. And strength. And during the 3 follow-up years, a lot of time loss injuries occurred in both groups. In basketball, 158, and in floorball, 144. Most of these injuries were lower extremity injuries. There were 4 ACL ruptures in the basketball group, 3 females, 1 male, and then 8 in floorball. All of them were in female players. And interestingly, in floorball, majority of injuries occurred, ankle and knee joint injuries occurred in non-contact circumstances, and that was also a case in basketball concerning knee injuries, but about half of ankle joint injuries occurred in contact situations, and those situations in basketball were stepping on another player's foot. That was the most common injury situation in basketball. And then I have some results already. We are still analyzing the data, but we have already published or prepared some manuscripts. And the first one here is about our main interest, is knee valgus movement during a vertical drop jump associated with ACL injury risk. So before this study and before the Norwegian and our study, there was one prospective study that had revealed that knee valgus in this particular test is associated with ACL injury risk. So we included only female players here because there were no ACL injuries there was only one ACL injury in boys group. And these players performed vertical drop jump tests, and then we collected injury information during the follow-up. And complete data was obtained from 171 female athletes, and there were 50 new ACL, non-contact ACL injuries during this 3-year study period. And here are the baseline test results of ACL injured knees and then uninjured knees. There are minor differences between these knees, injured and uninjured knees. However, our analysis revealed that knee valgus at initial contact, big knee abduction moment, medial knee displacement, and knee flexion at initial contact were not associated with ACL injury risk. 2 measures, 2 variables that were associated with ACL injury risk were peak knee flexion after the ground contact and big ground reaction force. So this means that those players who landed with stiff knees in this study were at a higher risk of knee injury. But it's good to remember that almost all of these players had difficulties with their knee control. So knee valgus was very common problem among all female players, almost all. But sensitivity and specificity was very poor, so we cannot predict injury, ACL injury, by using vertical drop jump test in this athlete group. And again, I have some videos to keep you awake. This is an ACL injury in floorball. This girl here, she was one of our study participants. So her left knee here. So she had difficulties in every test where we measured knee control, lower limb alignment, and she sustained 2 ACL injuries during this study. And then another example, again, floorball. The player is here, number 26, non-contact injury. This girl had perfect technique in every single test we measured, and she sustained 2 ACL injuries. Just 2 cases here that that I wanted to describe, that the technique in one single test doesn't reveal real injury risk, and also how much this kind of vertical drop jump test is related to floorball and those injury situations there. So first of all, this test doesn't mimic these real life injury situations very well. We have done some more like sport specific measures as well. So this is one of our direction change tasks from our 3-dimensional lab. And again, this is the girl who had 2 ACL injuries. And we are now analyzing this data. So perhaps we find something interesting from these tests, but I don't know. I doubt that we could predict injuries by using this kind of measurements. And these are from basketball. So you can use very different technique when you do your direction changes. Then we have also analyzed our strength tests. Jussi Hietamo is one of my PhD students. He's a medical doctor specializing in orthopedics, and he's interested in strength and association of the strength test with injury risk. And in this paper, he analyzed our leg press test, then isokinetic quadriceps and hamstring strength, and then hip abductor strength. And again, we collected information about knee injuries during the following years, and then did the analysis. So in univariate models, greater strength was associated with injury risk in both females and males. But in multivariable models, this was not significant anymore. But lesser hip abduction strength was associated with increased risk of all knee injuries in males, but not in females. But again, sensitivity and specificity was poor, so we cannot predict injuries by measuring players' strength. Also regarding this, that stronger guys have higher risk, there are probably a bunch of different confounding factors behind this. Stronger guys at this age group here are probably the most talented players. They probably play more in adult games. They probably are faster, they can turn faster, they jump higher. So there are many confounding factors, I assume. Then Anu Räisänen is Anu here? No, she's a postdoc in Cyprus, and she defended her PhD last May. And in her study, she looked at single leg squat, and she investigated whether knee valgus during this test was associated with higher incidence of injuries. And we have used this test in 2 studies, in this profit risk factor study and in our soccer study in younger soccer players as well. And in basketball and floorball, the results revealed that those players with higher knee valgus during this test were 2.7 times more likely to sustain a lower extremity injury and 2.4 times more likely to sustain an ankle injury. We didn't find any association between this test and knee injury. But again, sensitivity and specificity was poor, so we cannot use this test to find those players who are at the higher risk. And in our youth soccer cohort, we didn't find any association between frontal plane knee projection, ankle, and future lower extremity injuries. Then we have done one pooled analysis with Norwegians. We are planning to do some more later, but in this particular paper, we were interested in genes, and we assessed association of previously identified variants in genes encoding for college gene and the risk of ACL injury. And to our knowledge, this is the first prospective study investigating association between these variants and ACL injury risk. And altogether, there were 119 players with at least one ACL injury, and we didn't find any association between these variants and ACL rupture. Previous studies have been mostly case control studies, so this was interesting finding and different finding that those previous studies have revealed. Then about the Norwegian guys, they have published their main papers already, and none of the tested variables pointed out to be a risk factor for ACL injury in their cohort. Only previous ACL injury was associated with increased injury risk in Norway. So to conclude, it was a lot of work to carry out a cohort study over almost 5 years in Finland and 8 years in Norway, and none of our screening tests pointed out to be accurate enough to predict who will get injured. And this is quite logical, I must say, because assessment of risk factors is very complex. Risk factors are very complex, and most of these in sport do not act alone in isolation. And still today, there is lack of studies that use multifactorial approach to investigate risk factors, and lack of studies that take account the cyclic nature of changing risk factors. Because in our study, we collected baseline data in the beginning of each year, each season, and then we collected information about injuries and exposure, kind of assuming that these baseline properties stay same during the whole season. They can change. So this is not the best way to investigate risk factors, so to say. However, we know that injury prevention works. High quality studies have demonstrated that neuromuscular training can reduce injury in different sports, in different target groups, in different age groups, in both females and males by 30 to 65%. And all these training programs have been somewhat similar, containing sport-specific technique, for example, running technique drills, agility, hops and jumps, strengthening exercises, and balance exercises. And the key is to focus on movement quality, focus on proper knee control during direction changes, focus on proper knee control during walking lunges or landings from a jump. And the same warm-up program I used in my PhD studies was tested in soccer in Finland. So this was our large randomized control trial in youth soccer, where were 1,400 players, and they were randomized into intervention group and control group. And they did 20-week intervention period, and intervention group did, and control group were asked to continue their usual warm-up strategies. And we have just submitted this paper. Unfortunately, we were not able to collect exposure data, so we have just injuries and number of players. That's why I have this, how many injuries there were per player. And we didn't find any differences in all acute lower limb injuries between the groups, but there were differences in non-contact lower extremity injuries. So, and especially ankle sprain injuries, where incidence of ankle injuries was lower in the intervention group compared to control group. And interestingly, we find this lower injury rate in only boys, so not in a girls' population, because it also was clear after we visited the teams that girls' teams for some reason didn't use this program very well. I don't know what was the reason for that. We are working on the adherence paper next. So we have used the same warm-up program in soccer and find similar trend that we can decrease the injury risk. And now we are using this same program here in Calgary in basketball. And we have a basketball study in high schools. This is not a randomized control study. The first year here is a control year, so this is kind of historical control study. And during the first year, there were no intervention. And during the second year, we have an intervention warm-up program there. And we will compare these 2 years and incidences of injuries between these years. And we also use 2 different delivery methods when we implemented this prevention program to high school basketball. The first group was comprehensive delivery group, so they received extra support, and we visited these teams weekly to help coaches and players with this program. And then the second group was so-called standard group, and they didn't get any extra help with this program. So we will also investigate differences in injury rates between these 2 groups. And intervention program, in original one in floorball, it took 20 to 30 minutes to do. And in soccer, it was only 20 minutes. And now in basketball, we decided to have only 1 set of each exercise, and it takes about 10 minutes, actually 8 minutes. Is it 8? Yeah, 8 minutes to do at the beginning of all training sessions. So I don't know the results yet, but this will be interesting to see if there are differences between those 2 groups and also between 2 years. So what I think I'm going to do now, I would like to, and I'm going to still investigate knee and ankle joint injuries in different sports and risk factors for these injuries. But I really think that we need to have a deeper understanding of everyday load, everyday training load, how much our players jump, how often they perform direction changes. These are the situations where injuries usually occur. And we can collect this kind of information by using wearable devices. And I would also, I'm also planning to develop novel methods to, not myself, I'm not a biomechanist, but I have biomechanists helping me with this, to collect information about lower limb alignment during these situations in everyday training. Perhaps by that way we could have a deeper understanding in injury risks and how they differ between different individuals. And so far, injury mechanism studies and risk factor studies have focused on knee alignment, lower limb alignment at the point of foot contact. So maybe we should also investigate what happens before the impact here, because, well, for example, this picture shows quite nicely that this girl, before her ACL injury, her lower limb is already in not so good position here. So that would be one way to go as well. And also regarding neuromuscular training, which is effective in injury prevention, in future studies, I'm going to focus on implementation studies in more detail, because there are still too many teams, too many coaches, too many players who don't use these programs. So we need to understand why they don't use them, what are the barriers to use them, and how we could implement these evidence-based programs in the real world. Thank you. This is what we do in Finland. This is called winter swimming, and this sauna is from the UKK Institute where I worked. Not in this sauna, but and yeah, this is what we try to do every week. It's very refreshing during winter time. Yeah, but if you try this, don't go alone to the hole in the ice. This is good to remember. Safety first. Thank you.
Questions for Dr. Pasanen?
So you were showing that some of the neuromuscular training is providing a benefit. Why isn't it stronger? Do you think it's the adherence to the way that the exercises are performed, or?
Yeah, I think it's strongly related to adherence. Yeah, and there are some studies, and we also investigate adherence that have revealed that those who do these exercises regularly have lower rate of injuries compared to those who don't, which is logical. So you need to do this, you need to use this program to gain benefits. So yeah, adherence is a big issue. Yeah.
A lot of the videos show the knee always went into hyperextension prior to making contact with the ground. I think that could help potentially activate the hamstrings and maybe decrease quadricep activation. Then they actually are the body still moving forward in movement. That could actually put a lot of stress on the ACL.
Yeah, that's probably one thing that is also associated with injury risk, and there are some findings that knee overextension is related to higher risk of injury. But again, these are very small studies overall in the field of injury risks in ACL injuries. There is a lack of large prospective studies investigating this.
Would there be any way in the lab to look at, I don't know, flexing or that reflex or any of that?
Sorry, I didn't hear.
Would there be any way in the lab to look at that reflex or whatever, the ability to, if you inhibitor hamstring muscles?
Yeah, probably. Yeah, probably we could do that.
Parash?
Have you ever done any study to see how people would change their action when there's an unexpected change in the surface? For example, you did the direction study. So if for example, if the friction of the surface changes, how would they behave? Because a lot of videos that you showed, it looks like it's like an unexpected changes in whether if the dryness of the surfaces changes or something like that.
I haven't done much studies focusing on playing surfaces. However, in our floorball study, we found that injury rate is higher on artificial floors compared to wooden floors in our female cohort. But we didn't do any exact measures. We didn't measure the friction. That was just two types of floors, artificial and wooden floor. But that would be interesting to know, and I think that a gentleman sitting in front of you knows more about different playing surfaces and injury risk than I do.
Another question. A few times you mentioned focus on movement quality. Is that something that you assessed during them doing the training, or is it just instruction you gave to them to try and perform the movement differently, or how was that kind of implemented in the training?
Well, basically, when we implement these training programs in studies or in real life, we organize workshops for coaches, and usually these workshops are from 2 to 3 hours. I prefer 3 hours because then you have time to have a long theoretical part, and we can explain why we are using these exercises and why it is important to focus on proper technique in each exercise. And then we will walk through all these exercises during 1 or 2 hour practical session. And there we will again discuss about why it is so important to focus this and this and this. And I have found this very good way to sell this program to coaches, because they really can try those exercises themselves, and kind of they get an idea, okay, this is the challenging part, and this is something where I should focus in more detail. And yeah, so that's how we deliver the programs. And of course, there are differences between different coaches. Some of them are very keen to learn how to do and how to correct mistakes, but some of them feel that they don't have enough skills to correct players' mistakes. So that's life. That's how it goes.
Yes, you have basically two approaches. One is an approach where you do epidemiology, and one is an approach where you do training.
Mm-hmm.
And what do you think? Which of these approaches has had results or better results? The training approach or the epidemiology approach?
Better results.
If I understand correctly, Norway has a reduction of injuries of about 50% or something like that, very high.
Mm-hmm. Mm-hmm. Yeah.
Is it because they have learned a lot from the epidemiology, or is it because they have implemented?
They have done, they have done implementation there a lot. I think they are both very important pieces, but I prefer the training approach.
So what have you learned from the epidemiology approach?
I have learned a lot that what are the sports that have a high risk of injuries. And
But you knew that before.
yeah, but now I know it in more detail.
So you
Yeah.
know now that
Mm-hmm.
injury risk is 70% or whatever.
Mm-hmm. Yeah.
So
Yeah.
so what?
Yeah. We should do more implementation, I guess. I mean, in my opinion, the problem is that we can prevent injuries in these studies. Yes, when we have a controlled situation and we can meet these teams regularly and support them. But in the real life, it's more difficult, especially in Finland, I think, and also in other Nordic countries. Most of the coaches are volunteer coaches. They are history teachers. They are engineers. They don't necessarily have any kind of education regarding how to uh, teach proper technique. So it's quite challenging for them also to start using these programs because they don't necessarily understand all the important pieces.
Okay, that's a problem.
That's a
Still,
problem.
The basic question is, if you would have to stop one of the two approaches, which one you would stop?
Stop totally,
Yeah,
not using at all.
you are only allowed to use one.
Oh wow, okay. I'm an epidemiologist.
You could keep that or stop that.
I would keep that to follow injury rates.
Wow.
It would be nice to know, yeah, how they change or do they change. If I can change that later.
I raised my case.
You, in your intervention studies, and so you focused a lot on the biomechanics of the injury, you know, the knee twisting certain ways, and so and well, it's a question that I always ask people. You know, how much is actually the biological system responsible for the injury? You know, like the bone people, Brent. You know, maybe also interested in the biomechanics, but the first thing that bone people always seem to look at is what's the bone made of. You know, they do this micro CT and look at bone strengths, and then they predict, oh, this bone is very fragile and this is not. I always wonder if people do that also with ligament injuries and meniscal injuries and cartilage injuries and soft tissue injuries, because maybe the fact that you don't really find a lot of associations with the mechanics is maybe the biology is primarily responsible. And two people doing exactly the same movement, you know, one with the same loading, one will tear the ACL and the other one will not, because the biological strength of the tissue is different.
Yeah, I agree that probably plays a crucial role there. And also, I mean, even though we have two players performing same number of jumps in one practice, for example, the load between these two players can be totally different. And
but I mean, even if the load was the same, you know, and you know, I know from what Steve and Brent tell me, you know, you can load one bone in a certain way, it doesn't break, and you load another bone in the same way, and it absolutely breaks, just because the material property is so different. And we know in some tissues material properties differ a lot. And I'm not sure if that's true for ligaments as well.
Yeah.
The other thing that I had is that, you know, with the intervention studies that are successful in the neuromuscular intervention, it always surprises me because I always think of basketball player and also these floorball players. They seem very agile, and on the elite level they seem to be very good. It amazes me that their neuromuscular control could be improved a lot by doing specialized training. And I was wondering, has ever anybody done a placebo intervention study, you know?
I haven't seen any. That's a good question.
Because I wonder if you just, you know, you give everybody like a little rubber band around the wrist, and you would tell them, we know that this prevents you from getting injuries, so you're going to be better off, and you know, and you are in this group that is going to be less injured than these guys that don't get the armband. I just wonder if the awareness that you are in a group that's supposed to get this training that prevents you from injury, if that actually somehow plays tricks with you as you play, and that might actually explain for it, rather than neuromuscular training.
Yeah. And also, I totally agree. And we should do more of that kind of studies as well. But we don't know exactly what are the mechanisms of these prevention programs. We haven't done much studies before and after the intervention that what really changes. So yeah, there is a lack of that kind
But,
of
I mean, even if
studies.
it was a placebo effect,
Mhm.
it would still be good, if you prevent injuries, then who cares why you really
Yeah,
exactly
yeah,
happen.
yeah.
So when you do these training programs, sometimes you say 30 minutes and you do it 2-3 times a week. That's 60 or 90 minutes where you train, but you're not getting injured. Do you account for the fact that now you have less time? You train, I don't know, 15 hours, but now 1.5 hours is spent doing this and not getting injured. So I should have a 10% reduction because I'm doing the exercise where I could get injured 10% less or 20% less, depending on how much I train. Do people account for that as well?
I guess so. Yeah, I guess so.
And last but not least, there's always this argument that we do a lot of statistical analyses, and then the stuff we focus on are the significant results. And I saw lots and lots and lots of statistics that you did. Lots of it was not statistically significant. Could it be that a lot of the stuff that's statistically significant is actually by the 0.05 alpha level? Every 10 years time you get a significant result, and all these results are published, whereas all the other ones are downplayed. Because if you do enough studies and you do enough statistics on the 0.05 level, every 20 years time you're going to get randomly a statistically significant result, and then that gets published.
Yeah,
Is there
that's
any
true.
concern for that? Or?
Yeah, that's a concern. Of course it is. Yeah. And overall, even though these studies were relatively large cohort studies, we would need even larger cohort studies and maybe to do pooled analysis later to reach enough sample size.
Dr. Werthener at the back.
Thank you. And a follow-up, I guess, to Benno's question and leaving the placebo effect aside for a minute. I mean, in terms of the group that saw the 66% reduction rate in injuries, so was that the Norwegian group?
No, that was from Finland.
So
only we Finns can do that.
Okay, only Finnish can do that. So what did you do, or what did they do?
They
allowed that to happen.
Well, I think there are many different aspects why this study was so successful. It was floorball. I was a coach in floorball. I knew all those coaches. I knew where they lived. So it was easy to make them do and use this. I met them quite often, even though these teams were different parts of Finland. But because I was traveling with my team, I was coaching men's team at that time. So I met these guys. And of course, there were teams, and actually 3 coaches were not so happy with this program, and they think that it was bullshit. So they didn't use it, but all remaining teams were using it. So the adherence piece was quite good. So I think that was the important part why we were able to find such a big difference between intervention group and control group.
So did you find a difference between the teams that the coaches didn't want to do it?
Yes, we did. We did efficacy analysis. So when we compared only those teams who trained as we had planned, the reduction of non-contact injuries was even higher. So I guess it was 82%. So that was huge. But remember, we focused on non-contact injuries only. So I don't, and there were no differences in contact injuries, which is logical. There were a little bit lower rate in intervention group, but no significant difference.
So now that you left Finland, has anybody observed if the injury rates went back?
Yeah, I should check that.
because I remember I saw a person many years ago came and she talked about team handball and interventionist ACL injuries, and she also had this fantastic reduction. And then she said, and then the program was stopped. And in a year or two, the injury rates are right back again to where they were before.
Yeah.
So I just wondered if that happened in your case as well, or if anybody followed up.
I have to ask my students to do that. Yeah, that's a good point.
Has there been any attempt at correlating the injury risk with genetic predisposition? Like, have you genetically tested these people and seen if they have a particular gene expression that's common in the injury group?
No, we have done only this one genetic study focusing on ACL injuries and these gene variants.
Yeah.
Well, we have done some studies where in our baseline questionnaire, we ask that if these players' parents or siblings have had knee injury. We have also one sub-study focusing on low back pain. So we have asked that if parents or siblings have had back injuries, back problems. And yes, by this way, we have found some relationship between familiar predisposition, but it's based on the questionnaire and self-report system. So.
I'm not incredibly familiar with the neuromuscular training literature, but I've read my fair share to see that they're relatively similar. Different people have different training programs. They're relatively similar. And they seem to sort of be this magic pill. They prevent all-cause injuries. So I've seen research saying that it reduces ACL injury risk, ankle injuries, stress fractures, everything.
Stress fractures, well.
And I have a hard time, well, first we know that the mechanisms of injury for all these different lower extremity injuries are not the same. So I have a hard time thinking that these training programs are somehow preventing this injury from happening. I think it might be more likely that people are just not getting themselves into these injury situations.
Could be.
That makes sense. Which maybe goes to sort of the placebo effect. But I just wonder about publication bias in this field. Is it nearly impossible to get something published to say that we did a 6-month or a year-long training program and we found nothing?
Today, if you do a randomized controlled trial, you should also publish all those negative findings as well. So, yeah.
So
and there are some studies, quite good quality studies that haven't found any differences between groups. Yeah, there are, for example, in soccer, so in big sport, yeah. There are some studies in handball, I guess, that it's a Norwegian study and they didn't find any differences between two groups. So, yeah.
Good. Can you say from any of the research that you've done whether or not injuries are more likely to happen towards the end of a game?
There are some studies. We have also collected this information at what period it was and even the playing minute and time of the game. And also time of the season may affect as well. But because we don't have exact information that is related to everything, we haven't done any analysis of that. But there are some previous studies that have suggested that injury rates are higher right after season breaks. For example, when you return to play after a break around Christmas time. And injury rates in some sports have been higher, right, when players move from pre-season training to more sport-specific training. And also
Presumably
injury.
the load goes up.
Yeah, and also I'm a co-investigator in Finland in ice hockey study, and in our professional ice hockey injury rate seems to be higher during playoffs. So we haven't done any analysis what is the reason behind this, but it's probably related to training load, changes
intensity
in
of loading and stuff
yeah.
like that. But so many people do. You see biomechanical study after study after study that look at people in fatigue situations, neuromuscular fatigue situations. I just don't see enough literature that says injuries happen because people have neuromuscular fatigue.
Yeah.
So I was just wondering.
Yeah.
In skiing, in alpine skiing, that seems to be the case. Statistics about ACL injuries seem quite strong. That you have that more in the second half or even in the last quarter of the race rather than the first quarter. So in alpine skiing, there seems to be a direct correlation between the length of the run and when you get the injury.
Yeah.
Okay.
But that of course might also have to do that the first quarter of the run you're not quite as fast, and there might be other factors that play a role.
Still a question at the.
Nope.
You're good. Yeah, Walter.
So why do females have more ACL injuries in the same sport as males?
I think it's a complex thing. I mean, of course, there are some anatomical differences between males and females. Females, on average, have a wider pelvis. This may lead to differences on hip position, knee position. Females have looser ligaments. Ligament laxity is greater among females on average due to female hormones. There are also some studies that have shown that females have differences. When we compare males and females in same sport, females have weaker joint position sense in some tests. Okay, it's based on the test results, so is there a real difference? I don't know. So there are different factors behind that. And also, I don't know how much it is related to training habits and training strategies. If I think as a coach here, not as a researcher, I would say that in Finland, in female sports, coaches are less experienced. I was a coach, so and also in quite many cases, females start playing, especially team sports in Finland, about 2 or 3 years later than males. Is it related to your skill sets? Also, in Finland, females train a little bit less than males overall. So there are a bunch of different things probably that can be affected with that.
No, if somebody asked you, what do you think the main factor is? What would you think it is?
I think that
anatomy, or that's the one you mentioned first.
I think it's related to anatomy and this includes also ligaments and ligament laxity.
Any more questions for Dr. Pasanen?
I was going to make a comment on the placebo effect thing because we have the ice current study. So we did do a control or placebo warm up with some schools and coaches versus like the actual neuromuscular training one. So they're still finishing all the analysis for that. It was over multiple years with like 1,000 students, I think. And just for me, like I work in the strength and conditioning profession, I think it's the challenges is like how do you research that in some of the higher sports settings where you have strength and conditioning coaches that are on top of the literature a little bit more, and you're dealing with that gap. So I think like in some of the youth sports, we can potentially look at that a little bit. But I just know from like being in the field and going out and delivering the workshops, and we sometimes have this like kines teacher in the class that is like obviously what we're doing is not, you know, it's like kind of older or whatever. I think like designing the placebo I know is a challenge that we've had. So like with that, I just wonder like what like you would think about, yeah, if you're designing that or trying to even work in higher levels of sports, like where there would be opportunities to maybe tease that out.
Mm-hmm.
All right, any other questions? Let's thank Dr. Pasanen.
All right, next week our presenter will be Dr. Mike Monument, and he'll be speaking on mouse models of sarcoma and immunotherapy applications. See you next week.